Well, welcome everyone to our January meeting of the Adult Social Care, Health and Communities Overview and Scrutiny Committee. Welcome everyone. We've got an agenda in front of us. Welcome to people joining us online. And can I ask Democratic Services Officer to present apologies?
Thank you, Chair. We've received apologies from Councillor Fiona Baker. There is no substitute. Thank you.
Thank you. Welcome to Mel, for whom it's her, Mel Williams. You're very welcome to the committee for your first meeting here. So it's really good to do you want to just introduce yourself and just say where you've come from and, yeah.
So yes, this is sort of my first full meeting, because I did pop into a committee before and make an introduction, but no, I didn't stay to the end. So hello everybody, so I'm Melanie Williams, Executive Director of People. I started here in September, so I'm responsible for public health, adult social care and children's education services. So that's the remit I have. I'm really pleased to be here, so that there's a few things that I'm really passionate about that I'll be looking forward to talking through with committee, and we'll be touching some of them today. So the first is obviously about delivering excellent adult social care. So I worked in health and social care across the NHS and local government since I was 17, so you can work out your own maths as to how many years you think that is, and there'll be a prize at the end. The person who rates me the youngest. So I'm really passionate about that, really clear about giving people really good outcomes. And I think for local government, we do that by acting in a way that's as local as possible through co-production, which I know is a bit of jargon, but for me it means talking to people about what's important to them, listening to them, working with their family and their carers, and working hard to try and adapt what we do in a way that's personalised and puts their needs at the centre of it, really. So that's some of the things looking forward to do. And you'll hear when we talk about the priorities for the department later on, how that's sort of playing out in some of the work that our Cabinet member, Councillor Coos, wants to lead as well. So looking forward to that. So thank you for that welcome.
Thank you. And we're looking forward to working with you over the coming months. Declarations of interest. Do we have any declarations of interest that we need to make? In which case we can go on to item 3, which are the minutes of our meeting which took place on the 24th of November. Are they a correct record of that meeting? Rosie, Councillor Herring.
That's okay, Rosie will do. Is it not on? Yes. I wrote to you, so you knew that I was going to raise this. But at the last meeting, I was very alarmed at the presentation that said that there was an 18-month backlog for dolls, deprivation of liberty. And this concerned me, having been looking after elderly relatives and parents in previous times. I mean, I know it will cover probably mental health as well as the elderly. But I wanted to, I asked some questions about it. I asked how many people actually die waiting for their assessment. And I think there are some other questions we could be asking, like how the department triages, how many complaints we get over this deprivation of liberty. I may be misinterpreting the situation, I may be wrong, but I am presuming that it's when, and I'm thinking of the elderly rather than the mental health side, of where people have been discharged and are in a place where they do not wish to be, and their only recourse is through the application of deprivation of liberty to the council. But I might be wrong. But the 18-month backlog really worried me, because we could be talking about elderly, frail people who are dying in a place that they do not wish to be. That was my concern. But it wasn't minuted. That was the problem.
Yes. So I think we've now corrected that, have we, Richard? Or we can note it in these minutes as a correction to the minutes. And I think that I've certainly had a discussion with Richard about how we record kind of the discussion within the committee, and also that we're planning to have an action log from each meeting with things that we need to, action points that we need to pick up from the meeting, that we can make sure that Richard come in and yes.
Thank you, Chair. To address Councillor Herring, the minutes were updated, but prior to the published version being included in the agenda pack, so the question that you raised at the last meeting is included in the minutes of that meeting. I can read them to you if you want me to, but it is there. And on the action log, obviously, since this committee sort of came into being in May last year with the new administration, a significant amount of our time has been taken through information gathering. So an action log of who asks what and when and which officers are responsible and when a response is due by will help us in drilling down and getting information out of these meetings rather than having to include significant pieces of information in minutes and then people have to go trawling through minutes for that, and the action log will be appended to the work programme as well going forward. So hopefully that will go some way to digging important points out of lots of detail that we face with at the moment.
Yes.
So, Chair, so were the concerns raised by Councillor Herring addressed within the meeting? Okay, so could I propose that at the next regular performance report that we bring, because we bring it on a quarterly basis, that we bring an additional briefing attached to that as a deep dive about deprivation of liberty safeguards, because it's not that there's an 18-month backlog. So there's a triage system where we triage based on urgency, so that's the longest wait for that. But we use national guidelines to produce that because it was an unfunded change of legislation, and the government have not yet progressed the move to liberty protection safeguards. So it's been delayed by both this government and previous government on 3 occasions to relieve that change of legislation. So really happy to talk that through, talk about the risks, and really give assurance to committee about how we're ensuring that people who are subject to having their liberty deprived have their rights regarded. So it's not about detention. So that's, but we can have that conversation at a future report if that's okay.
Thank you. Yes.
I'd really appreciate that. Thank you. And it's no criticism of this individual council, because I realise, and it was pointed out, that this is a national issue and presumably caused by successive governments not addressing it. But I would really like to understand, because I wouldn't like to think of any of my elderly constituents being in a place that they shouldn't be. I do know of one at the moment, which, and it's my fellow councillor Rebecca Breeze, where they've been waiting 6 months for a lady who inherited some money. She was put into council care. She's inherited some money. I think we have the money on charge of it, and he wants to move her to a more salubrious setting. Now she has inherited money from her friend, and 6 months has gone by and he's tearing his hair out, not being able to actually achieve anything. But I could give you more detail. I don't know who to go to be honest, over it.
On that individual case example, please do give the details either to myself or Ashley. If you have them now, we'll take them later after the meeting, or you can just email us on that issue. That's not related to deprivation of liberty, but yes, very happy to add that as an addendum to report. And thank you for asking the question, Councillor Herring, because the way that we protect people who are most deprived in our in West North Hants is so essential. So I really appreciate having that interest in people in that way. Thank you.
Thank you. Right, I think I should move on to my... we need to approve the minutes. Do we agree the minutes? Thank you. So we're then I'm on to item 4 and my chair's announcements. So just to note that we're webcasting the meeting on YouTube, so we need to speak into our microphones, which we are all doing, which is excellent. We're not planning to have any fire drills this evening, so democratic service officers will deal with this if we have an emergency to deal with, which hopefully we won't. And hopefully you've got all your devices onto silent mode. Even I have. So, right, I want to just say that as part of the next item, I do want to pick up the adult services breakout group for last week's members' scrutiny session on the budget. I think Councillor Cowse and I were the only two people from the committee there, but you were there as well. Yeah. Yes, I do think it's really important that we capture. Well, there are notes from that meeting. Well, I'll come on to that later on, but I do want to make sure that we capture that as part of the next item. At which point, Melanie, challenges, priorities, the floor is yours.
Thank you, Chair. So what I really like is a really good conversation. So I don't want to just give everyone the opportunity to talk right through the presentation, but I wonder, Councillor Percy, if every now and again we pause and just see if there are reflections, because I'm going to cover a lot of ground, and you just make it more interesting rather than me talking for 20 minutes about the priorities. So my intention is, alongside with David, is we're going to really set the scene for what's happening across health and social care and particularly from my perspective, nationally. Bring that into then, what does that mean for us as a council? So what are some of the key issues? Then sort of translate that into what are the key priorities, because I understand that Councillor Coos has been asked to present on Cabinet member priorities, and then we're going to talk about what that will look like as a programme for the year. And along the way, what David and I intend to do is to give some indications, the sorts of areas that you may want to consider as a committee add into your work programme, some that relate to social care, some that relate to public health, but importantly, some that relate to our NHS partners or how we work together as a system. So that's the intention. So what I may do is pause every now and again and just look at you, and that's the cue to say, does anybody want to ask me something or go into more detail? Does that sound okay? But then if I'm taking too long, hurry me along as well. So I'm really here to be guided by you. What I thought would be really helpful is just to give the broader context as to what's been happening nationally. So the Department of Health and Social Care would describe as leading a programme of health and social care reform in the last number of years. So I'm sure that previous officers talked to you about the Health and Social Care Act and the creation of integrated care boards and some of the consequences that had for councils in terms of integration and in terms of public health and adult social care and health and wellbeing boards. So I'm sure that you're cited on some of that. The adult social care reforms haven't happened at the same pace as NHS reforms. So as you know, we now have an NHS 10-year plan which has some consequences for us. But there was a deliberate decision made in Department of Health and Social Care to exclude both public health and social care from that, although we work hand in glove with health, and there is no social care without health, and there certainly is no public health without health, is there? That was the decision made. So I'm going to sort of talk through some of the things that are paused, and I hadn't put on the list Councillor Herring, liberty, protection, safeguards, but that is one of the key areas of social care reform that has been, I think the Law Commission looked at that 7 years ago, so that's quite a long-standing piece. So thank you for nudging me on that. I missed that off my list. The thing that we have had that's been quite radical for us as a council, and indeed the sector, is Care Quality Commission assurance. So as a council, our services that provide personal care, so shared lives, reablement, regulated services such as care homes, some parts of supported living if they provide care, but most supported living is excluded. But those council-run services have had Care Quality Commission inspections for some time. So things like, our Obelisk and other services like that. What they brought in 2 years ago was that they wanted to baseline all councils and give councils a single word rating. So this was the first time we'd had inspection of adult social care for some 10 years, because inspection had been paused at that time, and we were, as a sector, doing sector-led improvements and marking our own homework. So this is one of the biggest single parts of adult social care reform, and it was supported by two important bits of reform running alongside it, and which were about increasing transparency. So one was about client level data. So in other words, the Department of Health and Social Care been able to have a look at what we do in terms of an individual's outcomes and improve the way that we had data. And then it was also about digitising adult social care. So integrated care systems will pass some money through to start digitising social care. Largely not council services, but largely the provider services, the things in the market that Ashley may touch on through the presentation. So that was partly why we had some of that digital transformation, to be able for the Care Quality Commission to have a look at how well we're doing. So as well as being able to see the data that we publish on ourselves and that the Department of Health and Social Care publishes, the CQC decided to undertake their assessment with two key tools. One was about asking us to produce a self-assessment, and I'm again assuming that committee saw this as part of West Northants' preparation. And then the main tool for them to have a look was to come and see the place. So come and meet staff, meet people with lived experience, meet some of our partners, and talk to people about how well West Northants performs. So that's a really key part of assurance. I think just on that to note that our report for our assessment is imminent. We're expecting that in the next week, and so it'll be a key agenda item at committee for the next meeting. So I'll be coming and talking through in huge detail about that report. So just sort of as a note that we haven't yet had that final report, but we are expecting it any day now. So that was a really important part of adult social care reform, this idea that, because people pay for care, so adult social care is not free, people pay for it through council tax, through the social care precept, and pay for it by client contributions. The idea was that you have this transparency of outcomes, so people know what they're getting and we're accountable for the care that we're giving. Really important piece of reform. The other reforms that government had planned for some time have been paused. So liberty, protection, safeguards is one, but importantly was charging reforms. So I'm sure you're aware that the Labour government paused that when they came in into power. The previous Conservative government had paused that following the announcement when Boris Johnson became Prime Minister that charging reforms were put back on. And indeed, these are paused from the Care Act 10 years ago. So we've been waiting 10 years for that charging reform. That's really important because at the moment, the way that people pay for care, how much they pay, and particularly if you're a working age adult, some of that lifetime cost you may face if you're a younger person receiving adult social care, it's not fair. So the way that we work that system isn't fair and reasonable. Although we have to charge, the council can't afford to run services without charging for it. So those reforms remain paused. So the technical status of them is that they're paused. So any time we could be facing that reform. What we're hoping is that the Casey Commission will start to have a look at some of those issues and really understand about whether adult social care should be free, what does good adult social care look like, and what should we as a civil society be expecting how we treat people with disability and who are older, and what does a good life mean for somebody with those issues. So that's what we're hoping for the Casey Commission. Again, I'm sure you've been briefed on this as a committee, but that was announced by Wes Streeting, Secretary of State, this time last year. So he announced it on the 2nd of January. The Casey Commission took some time to get going because Baroness Casey was already undertaking the review of sexual exploitation and had been put onto that work. So the Casey Commission really has got going, I suppose, in the last 6 months. They've held a number of stakeholder events in Parliament with professionals from the sector, so I attended that on behalf of the Association of Directors of Adult Services, and they've just now announced a public engagement piece. So one of the things, Richard, it might be useful if committee are interested is to have a link to how this committee may want to feed in their own individual views into the Casey Commission. Baroness Casey is due to report on phase 1 of that review into this year. We don't know whether it's going to be the spring, the summer, the autumn, the winter, because 2026 is 12 months long, but we're expecting phase 1 of the work. The second phase of the work is in 2028. So like I say, what I'm hoping it will do is to really describe what good adult social care looks like. What do we think about enabling somebody to have a good life? What does that mean? And importantly, how is that paid for? And what is a degree of national support, given this government's the aspiration for National Care Service? And what's the degree of local support, personalisation and community support that we'd expect to have? So they're the key parts of adult social care reform. So I just thought, Councillor Purcell, should I just pause there for a second and then Yep, see.
If I may, just a brief question. You're talking about increased transparency in reporting. Is that now enabling sort of benchmarking between authorities to be clearer as well, so you can see how West Northants performs against other authorities?
We've been able to do that with the Adult Social Care Outcomes Framework for some time. The problem with the Adult Social Care Outcomes Framework is that often the data is quite historical, so we're kind of looking at benchmarking data that's sort of 3 to 6 months old, or we do it on an annual cycle. And I mean, you know, I think it's quite warranted in public health where it takes some time to change the outcomes of a health population. But for someone's individual life to not be able to see what's happening currently, I think is the big change. So it's much more about our ability to understand what's happening on an individual level. We've been able to compare regionally, for example. We look at that as a group of directors of adult services regularly, so we can regularly compare our performance with others. And we produce data within our performance boards, and we look at that, don't we, Ashley, in comparison with national averages, with our neighbours, and also our statistical neighbour group, because across the region we're quite distinct as a unitary in the way that we are, but we have what we call statistical neighbours, so other unitary councils that are very similar with the population and demographics. So we can do that now, but the client level data is intended to, like I say, drill down much more. The transparency is much more about telling a public story and a narrative, because at the moment there's a whole range of different practice as to whether councils talk to their residents about how good they are or not. So the idea was that it was this way of being able to, with a single word rating, have that assessment to your residents.
The way the payment system works, and I'm thinking on the elderly side, is quite a sort of, you know, sharp cliff. You're either in full payment or you get everything. You know, depending on what your savings are. But I know that when we allocate somebody into care, that we can take a charge on their property. But I never could see where the line of the money that must now be coming back in lies when I was looking at the budget. And I always worried that it was going into an amorphous finance instead of it actually being paid back into the service that had paid for it. Do you have any comments on that?
Yeah, so in our budgeting round, in adult social care, we're unique because we have what's called a gross and a net budget. The council publishes its net budget, so that's the amount of money that I draw upon out of council tax funds to pay for the services. But we also look at what our gross budget is, so that includes all of the other income we get, so income from the NHS, income from grants, and income from people themselves. And that runs directly back out into services, so that does come into our baseline within adult social care. It doesn't go into other parts of the council. And you're right about the charging reform. So at the moment there's a system that isn't sufficient for understanding about what's a disability related expenditure or how we take into account capital. So we have a charging policy, we publish it, and it's run in Ashley's area, but nationally it's a system that I would say isn't fair. And particularly when you think about people paying for their own care, they don't get necessarily the sorts of support that we would give in supporting people to make wise decisions, have people sort of understanding the contract, if you like, for their care. There's a whole lot of inequalities as well as actually how much people pay. Is there anything to add, Ashley?
But that's the amount that you claim, you know, when you say that you've got to part pay for your care. But do you have any difficulty? I suppose that's what I was wondering about our legal department, actually, and the cooperation between when you've taken a charge of a property in actually getting money when somebody's died or the property is sold, getting your money back. And I wondered what the relationship was between the departments.
Thank you, Chair. I don't really know how to phrase this question without appearing to be extremely rude. My husband has just spent 6 weeks in hospital, variant places. I am appalled at, 1, the standard of care under the NHS. 2, the lack of follow-up and, how can I say, people who appear to explain what can be done under the system offered. My husband and I are educated people with our own property, our own income, and stocks and shares. But 90% of the people that he has shared a ward with, alongside, in all places he has been, are ill-equipped to cope for the journey ahead. Now, he is 90. The majority of people that he was working alongside, because he had a stroke and a heart attack, a bleed, and a broken hip, were of a similar nature. And it seems to me as a councillor, and certainly the chair of the council, it behoves us to somehow clean up our act, because the lack of support within the venue is atrocious. Now, if you start in the basement, you can only go up. And maybe this is something that I should do when I'm no longer chair, to start that campaign to see what we can do in our council to improve the system, not only for those that can afford to pay for their care, but 90% that we've come across who certainly can't afford to pay for their care and have very little support and welfare at their bedside to help them. Now, my criticism is not, please, of you. It's just, where do we begin? Because the bottom has fallen out of the pail.
Thank you, Alison. And I think very often issues that are raised, you know, 76 councillors, we represent all our communities, and we will be in touch with the whole range of human experience, and especially, you know, people kind of when things are hard, and it's using that experience and feeding it through that it is our responsibility to raise these issues and to make the changes so that everyone gets the care that we would expect them to. And so, yes, I think we have to use our personal experience and use that to improve our services and link that with, we will be receiving the report from the CQC report. We then need to make the links between what they observe with our personal experience and test the two out. And really, and I think we've got, this committee, we've kind of got off to a slow start, but I think we've got a lot of very serious issues to consider in the coming months, because this is not an easy area, and we have to use our experience, because, that's ever so valuable. And certainly some of my councillor colleagues have used that, and we've managed to achieve changes through that.
Yes, Councillor Purser, I absolutely agree with you. It places a burden on your shoulders, but unfortunately, if the system is broken, I'm not saying you mend the broken system, you start with a new system to elevate it if you can, but I don't think you can. I think by the look of your face, if I might say so, it means we've got to mend the system that is there and is broken. And if it is as serious as I think it is, it's quite detrimental to our race. And we say that 65% of all funding in this council actually goes towards social care and children. There's very little left, but what is being done with that 65% on the allocation of the elderly is really what I'm on about. Anyway, I leave that question with you, and I'm sure that Andrew's now got something to say.
Yeah. If I may, Chair, I think, I don't know whether it's broken's the right word, but very inconsistent, because my father had a fall, was in hospital, discharged. The next day, somebody came around to assess him. The day after that, somebody came around with some walking aids for him, and my parents were very impressed by that service. And I said to them, "Do you know who it was who was providing that service?" And they didn't, and that was probably part of the transparency and getting that communication out. But so his experience was really good, but it's inconsistent, because you do hear quite a mixed picture from people. So I just thought it was important to just make that point, if that's right, Chair.
Delighted to hear it. The man who came to see my husband after the first stroke arrived when they had discharged us from hospital after 48 hours with something called a clot buster. He should never have been discharged, and the net result was the heart attack and the whole jamboree thereafter. My point is, I'm delighted that he was caught in a good web. What I'm appalled about is that we have the wherewithal to provide for Tim. We can do it irrespective of, with or without. But 90% of the people on the wards I've seen would never make that net. And what happens to them? And I have actually sat at one or two bedsides, and there are tears, there are relations who are utterly desperate. One of them said on the desk, "Well, go and talk to Alison. She'll be able to pick it up with the council." It's just coincidental. I never planned, one, that I would be on this particular scrutiny committee, two, that this would be a subject matter that would come up 6 months later. And I do think it's something that, unfortunately, we do and have a conscience about it. And surely the pair of you went into this field because you feel for the field in which we are. And it's really a question of how do we approach it to ensure that we catch that 90%.
while we're sharing stories, I spent the weekend in the Victoria Hospital in Blackpool with my 96-year-old mother-in-law who'd come from a rehab care setting, but she developed an infection and they wanted her to go back to the hospital because she'd been discharged too early. But they wouldn't wait to find her a bed on a ward. She had to go through the A&E system again. So she spent 3 days in a corridor on a trolley. She wasn't being fed. She wasn't being turned. She wasn't receiving water. There was nowhere to actually put a cup of water, and there was no call button. And when I've come home and, you know, I did everything I could, and she's in a ward now, and I've told them my concerns about getting her to eat. They only provide sandwiches in the A&E department, but they'd give her a packet of sandwiches. She wasn't capable of even opening them without us actually being there. There was nobody there to help. And I thought afterwards, even restaurants have a call system, have a pager. Why can't they actually give patients who are on trolleys that are in areas that they're not supposed to be, but at least give them a capacity to be able to call somebody? And I just wondered what the situation was in our acute hospital. And yeah, it just seemed like a very simple thing to be able to ask for.
I mean, I think one of the challenges to this committee is that so far we have actually, and by design, operated in quite a siloed way so far. And I think our challenge is, as we, in a way, it's a pity there aren't health representatives here tonight to hear Mel's presentation, which is relevant to them, but also the experience that people have had. So we do begin to sort out some of this difficult interface between health and care, because as a nation we're not getting it right at the moment, and we've got to improve it. So Mel, we're going to be here till midnight, aren't we? At this rate.
Can I just add?
No.
Can I just add one comment to that? We, as the council, in my opinion, need to hold the NHS to account within our hospitals, within our area. And if we don't, then although they are providing, if we don't hold them to account, we are failing in our duty, because we have provision through government to be able to make that provision.
So I wonder whether I don't know, I'll take advice on this, but whether we can always have a health representative at the committee, because the issues are relate to the. I mean, is that your role, David? Where do you get?
Chair, I mean, my professional advice would be that when there is a health item, we invite the relevant parts of the system, because there are so many different components to health. And David's offered to just sort of step in a little bit, as well as the role of Director of Public Health. But because, you know, if we're talking about corridor care, that's absolutely not about the integration of health and social care. I have no role. Also by geriatric care, hospital admissions, I have, you know, my powers are far-reaching, but there's a limit. So there are some things that are certainly to do with health and certainly to do with the hospital. But even within a hospital, there are different departments and areas. So my professional steer would be that we look at the forward plan, and then we get the right attendance for that item. But David?
No, completely agree with Mal. And in a second, I'll very briefly touch upon some of the sort of legislation around public health. But I think there are those opportunities to think about bringing ICB colleagues. We'll talk about some of the NHS reforms going on and about 10-year plans that are being put in place and 5-year commissioning strategies. There's an opportunity to bring health colleagues in to do something similar to what we're doing today, to actually think about their horizon scanning and the things that, as a system, from a health perspective, they're thinking about. So I think there's definitely opportunity there to bring them in around the table. Just to sort of move us on, because I know Mel will want to move on to the other slides, where I will just briefly share, and you're probably very much aware, from a public health perspective and from a wider health and wellbeing perspective, we still have the changes in 2012 around the NHS Act that puts that duty and responsibility on the council around health and wellbeing. It's a deliberately broad duty, applies to the council as a whole. Alongside that is our public health grant, which is a ring-fence grant with conditions that are attached to it, and alongside those conditions come a number of mandated functions that we must do related to things like sexual health, our provision of 0 to 19 health visiting mandated checks, NHS health checks, our measurement of children when they start and leave primary school around their weight. So a range of things that we're required to do alongside that responsibility to provide services for the need in the population. And in that sort of idea around assurance and where we have to sort of have our framework in terms of myself and the Section 151 officer on an annual basis providing those reports about how we will spend the public health grant in keeping with the guidance, and then signing off at the end of the year that we confirm that we have spent our grant in compliance with those grant conditions. So I thought I'd keep that brief, but just to provide that same legislative background to that duty as the public health grant, but that not being the whole part of actually that duty, wider duty for the council around health and wellbeing as well.
Okay, and just to conclude that slide, I thought it would be really helpful intelligence to understand that the Department of Health and Social Care are looking in this spirit of transparency and to be increasing the directors and my accountability. I know that David said he has a responsibility to sign off the conditions of the grant. Department of Health and Social Care are going to be increasing the conditions on me to be saying that council resources are being spent in Care Act delivery. So what I think is to be a really helpful tool for you, because as well as some of these benchmarking in Councillor Simpson that you mentioned, and we can bring how we compare, you'll also have a view from the government about how well West Northampton is increasing the fee uplifts to providers, meeting our Care Act requirements. We will debate about whether we think they're right in their assumptions, but it will be just an interesting source of information and you having a look at our performance. So I thought I'd just really whiz through some of the other technology and digital innovations. There's some national work, so we've gone to the next slide, to have a look at the ethical standards for artificial intelligence and sort of ambient voice, machine learning, some of those tools that are happening. The Department of Health and Social Care is investing in some that work to have some national ethical standards for social work. But nonetheless, there's an expectation that as a council we'll be investing in technology, we're looking about assistive technology and doing what we can to be investing in thriving lives. And we'll be touching on that later in the priorities because we'll be bringing forward a technology-enabled care strategy. As a council, we've invested heavily in tools that help us with colleague productivity. And that again has got a big national drive. So we think about case finding, ambient voice, which is a way of dictating an interaction, and that gets put into care notes, and magic notes is the tool that we're using here. You've probably heard about our AI system that we've launched called Rose. So again, there's sort of this national push to be developing some of those digital transformations as well. So can I go on to the next slide, please? So David, do you want to touch on, given I've done a lot of talking today, you want to cover off some of the NHS reforms?
That helps, thank you. So, yes, you'll probably be aware of the NHS 10-year plan that sets out 3 key shifts in the way that the health and care system works in terms of that movement of care from hospital to community, thinking about, as Mal has just mentioned, how we turn from an analogue health service to a more digital health service, and then also thinking about how we move from sickness to prevention. And what sort of come since then is a range of various different changes to NHS reforms in the way that they think. And we've mentioned the idea of that shift towards neighbourhoods and changing the role of our integrated care boards. What I'll say first is the geography of those integrated care boards is also been changing. You'll probably be very much aware that our integrated care board in Northamptonshire has joined and clustered with Leicester, Leicestershire and Rutland. to form one clustered ICB, and is working through that change and transition at the moment with its workforce and staff, and sort of creating a new ICB workforce structure to do that. And that links to its role and shift towards becoming a much more strategic commissioner, and thinking about how it has a relationship with neighbourhoods and commissioning neighbourhood organisations to deliver health at a place level. For us, it's that challenge of how do we represent place in an ICB that covers a much larger geography with much more, even more diverse communities than we already have and work with the ICB in favour for. In relation to that work, some of the work that we've done in particular, and we'll talk about the health and wellbeing strategy later, but this morning talking about how the role of Place Board within West Northamptonshire can help us find that line of sight from our communities, through LAPS, through Place Board and Health and Wellbeing Board into those larger ICB clusters. What we're expecting and have been waiting on is guidance for NHS colleagues around the development of neighbourhood plans, which outline that new way of working for the ICB at a neighbourhood level, and in particular for me in public health, one of the key focus points of that is around some of the population health management work they do, so thinking about the data and how we look at the need in our population so that we can design services around the experiences of people in our local communities. What we're still waiting, I suppose, to some degree, as part of those neighbourhood plans then, is thinking about, as a strategic commissioner, how will the ICB have those relationships at a place and neighbourhood level with organisations to provide care at that sort of smaller geography. There's a lot of waiting in there, I've mentioned, and as that guidance comes out, those neighbourhood plans will be fleshed out by the ICB in collaboration with us, and go to the Health and Wellbeing Board for sign-off and approval and involvement. The other thing that ICB colleagues are working on at the moment, and unfortunately it's come due to the way then delays in guidance a little bit back to front, is around their 5-year commissioning strategies for thinking for their priorities as an ICB at a bigger geography for the next 5 years in terms of commissioning, and those sort of workshops have started in the last month, and we've started having conversations with the ICB about being around those tables and being involved in the conversation about how we sort of reflect our needs in place and how that translates into their strategic intentions for the next 5 years. Is there anything else you wanted to add, Bill?
And just to touch on that last point about there being less arm's length bodies, so the key one for us is about Health Watch. So the 10-year plan, it said that a number of functions would be centralised. So I won't list all of the NHS organisations, but the one that we value locally and have a contract with is Health Watch, and we're not yet clear, are we, David, about what that future looks like. Will be commissioned through Ash's team. Okay, and then I just thought I'd touch on Mental Health Act reforms. So Mental Health Act reforms have been, again, a long promise, but they are actually happening with a 10-year implementation, so it's going to be a long wait before these come through. So I'm sure you're aware, but as a council, we have a role in mental health in 2 ways. One through some of our social work interventions, and the other through public health and through our commissioning, predominantly about public mental health prevention, which is all age. So there's an all age link there. But from a social care perspective, the Mental Health Act reforms predominantly hit social care services, and we've made some changes to the approved mental health practitioner role. This is a service that we share with Northants, so it's a jointly run service. Some of the brilliant things in the Mental Health Act that I think are going to transform people's lives is it will change the way that we detain people with learning disability and autism, and make quite dramatic changes that you can no longer be detained just by having a learning disability, which I think this is long overdue. So that's a really important step. We're not quite sure what that will look like for people who have great support needs, and we currently rely on NHS institutions to give that support, so it takes some working through as to what would a community support offer look like, but I think it's a really important shift. We'll also be expecting to be increasing our commissioning and use of advocacy, so that was an important part of the Mental Health Act reforms, and particularly culturally appropriate support. So this refers to the fact that there are groups of people, predominantly black men and Asian women, who are disproportionately represented in mental health detentions. So the idea is that we address some of those inequalities in the work we do, and we develop culturally appropriate support. So that's kind of a canter through all the big changes. So thank you for listening and engaging in that. But before we move on to priorities, were there any other questions about the reforms?
We just going back to what David was saying, that they're talking about it being more local and more neighbourhood, but all the time they seem to be creating bigger and bigger conglomerates and looking at big data and ignoring the fact that it's actually down at local level that they need to be operating. I'm particularly concerned for my local area because our population and that of Brackley and in the south actually look to the Oxfordshire system. They do not look to Northampton and Leicester. And so I don't know how we keep that cohort in play. And also, I haven't volunteered for the LAPs, but they've amalgamated the rural south, so we did have a LAP for our area. Now it's the whole of Brackley, Towcester and Daventry, basically the whole of the rural area, which is a big population and doesn't seem to be neighbourhood and local at all. What's their definition of neighbourhood?
It's a good question. I think that the definition of neighbourhood that is being used by the NHS is probably, I think we'd agree, is probably not one that our residents would assume in terms of what they, if we talk to them about what neighbourhoods mean. What I would say is what we need to do is think about how we put the things in place to help us create that line of sight from communities all the way up. I know there's a journey that LAPs have been on, and there's some learning that we need to take from what's been done in the past. And I think there's a way in which we think about how we include town and parish councils and think about that flow of connection from communities through LAPs up into Place Board and Health and Wellbeing Board. And I think if we can get that right, that is where we can have that impact by aligning the LAPs with the NHS neighbourhoods, because we can raise the voice of the residents that they're designing services for at that same geography. I get that it's not ideal in terms of the way that residents talk about neighbourhoods, to talk about local places. I think it's on us now, sort of as a system, to think about how we work together to tell those stories of residents. And I think we've definitely got a structure in place in which we can do that if we work together on how we maximise the impact of LAPs.
Just a comment for somebody who was involved in the original LAPs and how my biggest frustration was that they allocated lots of managerial time, but they didn't allocate a budget. And even a very small budget would have made a difference and made it not a talking shop, but actually got people at the table actually engaged. And it was a real mistake.
Alison.
Can I just quickly follow up on that particular point, is that the new LAPs have a community investment fund that will be attached to them, which is a fund of 150,000, which is jointly funded by Public Health and Communities. In actual fact, I think the first year of that, actually, it goes live this month for community groups to apply for grants of up to £7,500. So yeah, so those opportunities will exist.
Thank you, Chair. Along with Rosie, I sat on the LAPs. Area 3, I think they called it. Anyway, it's neither here nor there. The difficulty for people locally in Northampton or West WNC is that myself and the other two boards handle 31 villages. Boddington does not equate with Middleton Cheney or indeed with Brackley, which is now a township, and Towcester. So just to bear that in mind, if Charles, myself and David handle 31 villages, how many of the other councillors handle the rest and how is it broken
13
down?
or 14.
Well, there you go. And our brief is wide. Our geography is impossible. And I think the concept of the lapse was a good one. The result was a failure due to lack of communication and lack of funds. You've covered that one. The other thing is that I would say is over the 5 and 10 year plan, it's great to sit around a round table. It's great to be able to talk. What about implementation?
So, Alison, I think the challenge for this committee really is at the one level to get the strategy right, or look at the strategy and challenge that in its, and that's happening within a changing framework. So that's one bit. Then we've got how do we relate that to our communities and the variety of communities, because I can say that the drive in Abington is very different to Derby Road, which is just off that street. So they are two very, very different communities within one local area of town. So how do we get that sense of the localism of communities and the different needs that presents? And then relating back to the challenge of individuals and making sure that individuals within our community are getting the right services at the right time. And that is the challenge for this group. How do we keep the kind of the macro with the micro? And we've got to keep hold of the micro because it's very easy to get into the world of strategies here, and we've got to be looking about how is that impacting on people as individuals. And that's our challenge as members, to keep that kind of dynamic going. Right, do we need some action points from this for tonight?
We're coming on to that, so if
right.
we can finish through. So Laura was going to introduce the priorities, and then
right.
the team.
So I'm just going to read out what we've got here, and then Mel and David will tell you more about it. We've got the joint health and wellbeing strategy and the neighbourhood health and integration. We've got our adult social care vision and strategy, which is local account and launching the big conversations. Mel is going to definitely tell you about that one. It's quite exciting. We're going to be working on co-production, Director of Public Health, David John's report, and the Voice of the Child, West Northampton's co-production framework and strategy, and again, big conversations. The prevention and early intervention strategies are coming in. There's a lot of strategies, but they're really good. Wellbeing approach, integrated neighbourhood teams, and the best start and ageing well. And these are incorporating these people at home. So we're going to be taking the care to them at home. And there will be a lot of information coming forward about these and how it's going to work, working with the LAPs and the neighbourhoods. So we're just trying to make sure all the ingredients mix. I'm going back to kitchen talk again. The adult social care sustainability and the adult social care market shaping and fee strategy. So we've got quite a few priorities here. Mel, would you like to take on from that?
I'll jump in with the first one around joint health and wellbeing strategy. You might all be aware of the current health and wellbeing strategy, Live Your Best Life. It was developed alongside the Northamptonshire ICB priorities. There are a long list of priorities there. I think there's 10 priorities. As part of the refresh for the next 3 years, what we've done is gone, actually, we were spreading ourselves, I think, probably as a system slightly too thin in terms of trying to think about how we can impact on all of those 10 priorities at the same time. And actually what there is a need for some concerted effort as a system as to how we can add value to some particular areas of focus. And those have been identified based on some core principles and some workshops across with health and voluntary sector partners. Best start in life, which I think is, as mentioned later on down, which is a really key focus for us, and working across public health with children education around how we build a best start in life strategy. That's the first 5 years of life, so thinking from pregnancy through till starting school. Opportunities to be fit, well and independent is all of our work around thinking about that working well and the approach that we take to employment and healthy employment. Well, which links to my next one around employment that keeps people and their families out of poverty. And then the fourth one, which is around access to health and social care, which at the moment we're considering whether it forms part of the health and wellbeing strategy refresh or whether it sits better as part of our work around the neighbourhood plans and neighbourhood working and the governance that sits around neighbourhoods in terms of how we will sort of take that forward. Talking about strategies is one thing. What we're doing with those 4 priority areas is then developing a delivery plan for the next 3 years that says what we will do against each of those strategies. And this morning we were discussing with Place Board about making sure that we have really distinct roles for the Health and Wellbeing Board as a strategic partner setting the direction of travel, and the Place Board as a sort of delivery mechanism by which those delivery plans are delivered by subgroups of system partners coming together around those specific topics, but challenged by that Place Board and that system to ensure progress and ensure sort of accountability as to sort of outputs and outcomes that we've said we want to produce in that work. Similarly, thinking about as we move into that sort of neighbourhood health arena, using that Place Board to align alongside the ICB structure around neighbourhood health and to have those opportunities to think about the priorities at a neighbourhood level, challenge those and ensure that they are aligned with those health and wellbeing priorities that the Health and Wellbeing Board is setting out. And again, using Place Board as a lever for that, bringing partners together to have that sort of environment to have those discussions. I'll hand over to Mel.
Sorry, I couldn't work out within those 4 priorities where something that really concerns me fits. When we formed West Northants and we started with a lot of health data, it was apparent that we were massively out of kilter with the national statistics on suicide and self-harm. And we did some work on young people and mental health and supporting in the community, but I couldn't see where in those priorities and strategies that work stream would fit.
So what I would say is that those 4 priorities aren't the only things that we will do as a public health team. Those are where we think there is potential for that additional value that those system partners can bring by coming together. We have the mental health, learning disabilities and autism collaborative, which we're trying to think about how we work more closely with. And at the moment, my team is is working with partners to develop a new suicide prevention strategy and delivery plan that's linked to that. So whilst it's not identified as a health and wellbeing priority, it is still there happening in the background. The reason the priorities are there is sort of how we can use the health and wellbeing board and the system to sort of kickstart some of those areas where actually there isn't as much happening as we like, and we need more system collaboration to occur. Where there is some sort of good system collaboration happening, and I think mental health is one of those areas where we have that, there are opportunities then to develop still strategies on existing infrastructure and governance that we've got.
I must say, given that the data, and I don't know what the current data is, but given that the data was so startling, I would have liked to have seen it as a priority up front and you know, in your face, because it was really worrying. Maybe it's calmed down, maybe it's solved itself, but it was startling in comparison to national statistics, and something that we should be addressing and could address very much in partnership with the NHS.
Yes.
And what we were looking at was to trying to do more at a local level with the crisis cafes and the time to talk young people, and through the school system, of trying to get more help earlier to stop things escalating to the extent that they were in A&E having harmed.
Yeah, so you will definitely see a new suicide prevention strategy coming out. It's being worked on at the moment to sort of refresh and redo that strategy and take the learning from the previous strategy. The other bit I would highlight is the Health and Wellbeing Board, similar to you, has been very vocal on making sure that every single one of those work streams considers mental health alongside physical health when we're looking at Best Start, how we think about parent-infant relationships, how we think about the mental health of parents, and both sort of during pregnancy and thereafter in those first 5 years, and how we can support those families. So I'd look to try and reassure you, and we can bring some things back in the future potentially around, but look to reassure you that mental health definitely is a key part of all of those programmes of work.
I'd like to just add on to that, Councillor Herring. I have been quite involved in the suicide prevention team over the last year, and they are still going really, really strong. It's not like they're in the background at all. They are not. They really are still going quite strong, and with the new strategy coming in, I should imagine, you may correct me if I'm wrong, but working with the neighbourhood plans and the family hubs and putting that all together, the suicide prevention and mental health teams will be in there as well at some point somehow.
So with our new action system, perhaps we could ask for the data to be refreshed and brought to this committee next time, comparing both suicide and self-harm against national statistics, just to see which direction it's going in. Thank you.
An information report. It seems a very distinct bit that we can just circulate.
I think that would be really useful, and then we can decide as a committee whether we actually, it's the sort of topic that if we're concerned about it, we might then want to go on and do a deep dive into that, a sort of short specific piece of work.
Yeah, thank you, Chair. I mean, being new to the committee, sort of quite mind-boggling when you start talking about all these different strategies. You know, strategies coming out of our ears by the sounds of things. And I think it's understanding what the outcomes we're trying to get from those strategies, what the deliverables are, that I think will make it much more, you know, realistic and understandable. So I don't know how we approach that, Chair, but, you know, having a sort of, when you look at those strategies, you go, well, what's the first one trying to achieve? Even if it's just the top 5 things, you know, if you can nail it down, because I know it's a big area we're talking about, but it would just help, I think, trying to understand why are we doing it? What's the actual? Why are we trying to make how are we making people's lives better by having this strategy? It seems to be.
last three. So obviously, we've talked a bit and hinted a bit about prevention and early intervention. That one isn't working. Okay, yeah, I can tell now. And I don't want to mention strategies again, Councillor Simpson, but we will. And a big part of this is the development of our digital and technology strategy. I think it's something that's really popular with local authorities in terms of development at the moment because it's successful. I think the reality is, from speaking to people, is that they don't want intrusive care services. They want to, if they do need support, they want support where they don't feel like they're having their lives intruded on. And this technology strategy is going to set out how we achieve that and how we stop people from going into or requiring formal care and support in the first place, but also where they do, let's make it as little intrusive as possible. So we'll be proposing to bring that back later on, and that's going to be a big start. But I think one of the important parts for us is that we have an adults prevention strategy, and it focuses on how we, reduce deterioration, and we can support people and intervene where people might have a crisis, etc. But the reality is it all starts when people are young, and we're looking at that connection between the children's prevention strategy and the adults prevention strategy and ensuring that those are tied up and linked well. And my commissioners will be working on that as a priority in 2026. In terms of the sustainability plan, it's a very popular subject, this one, because I think Councillor Pearce has already asked for a separate briefing on the adult sustainability plan. It's the 58 different activities that we're pursuing at the moment in order to look at opportunities to, 1, save money, 2, get efficiencies, and 3, deliver a sustainable budget. So we've got a ginormous plan that we're working through at the moment, which sets out and to look at addressing how we can address the budget gap that we've got, but also how we're going to mitigate against future ongoing challenges that we might have unless we make interventions now that are going to reduce the amount of demand that are coming through. So I think you've asked for a separate session on that one. Otherwise, I will talk you for the rest of the night, and I know people do want to go home tonight. And then I think lastly, I'll just cover quickly about our market shaping plans and fee strategy. So there is a proposal about how we'll be addressing our contracted rates in terms of the rising national living wage and consumer price index with effect from the 1st of April. So we're working on our proposal about what that looks like and how we can look at be fair and equitable in terms of what we pay our contracted market. In terms of market shaping plans, there's 2 key parts for us for next year. One is the transitions pathway, which transitions is where people transition from children's services into adult services. So we do want an approach where it's an enabled approach, and we're looking at that enabled pathway. That means they have less of a need for support, and again we talk about intrusive support as they move into adulthood. And similarly, hospital pathways is a big part for us, ensuring that people do get the discharges in a timely manner, but to the right services, and those services that are going to minimise the risk of people ending up back in hospital and requiring more support and having more intrusive services than they were before. So those are the key parts of our market shaping plans, and obviously we'll talk more detail as the year goes on.
Right. No.
We have the last slide. So this is just the milestone. So you've said, well, what's happening and when? So the next one after that, please, David. So this is when we're delivering all the things we've talked about today. So some of these are cabinet decisions, such as the local account next week. Others are the timing that we'll be developing things. So there's opportunities for us to come back on specific issues, engage. So that's a forward look for the year. So thank you.
Right, thank you. Let me try and see if we can kind of work out how we as a committee engage with this. The sustainability issue, I think the recommendation from last week's joint place scrutiny meeting was that we set up a joint, I suppose it's a task and finish group, to look at the 58 action points that you've got and for us to understand and I'm not sure what our role is, but to monitor the progress on that, to understand what are the ones that are deliverable and what are the ones that are difficult, really, perhaps, so that we as members have a better understanding of what's going on, because I'm not sure I have a better understanding after last week's meeting, but it could be even better so that we actually really have a grasp of what the challenges are in this area. So I would be keen, actually, I would have thought if Place Scrutiny sets up a joint group with us, if we had 3 members who are willing to serve on that sort of group, I think that would be really useful. And I'm kind of looking for people who might be interested in joining that group. I'd like to put myself forward as one of the people. And Andrew?
Forgive me at this moment.
No. Yes. Shall we send an email out to members of this group to ask for because I do think as a committee we need to get our heads round the financial aspects of this and the financial implications for the authority, because my view from last week, well, I think I knew as a kind of that it was difficult and challenging. I think I now understand more about how difficult and how challenging and what a priority it is for the authority to really get to grasp this in its detail, as well as the sort of ballpark figures. So are people happy for us to go forward with that? And we'll send out an email inviting people to join that group. Great, thank you. So that's an action. So, any other specific actions from the present? So it sounds like there are a number of strategies that will go to Cabinet. Some of them might well come to this committee prior to Cabinet for us to look at an early enough stage so that we can have a sort of impact on it. That would be good. So perhaps if the committee are happy for me to meet with Mel to work out when and where that is most useful to come. We've certainly got, so it looks like our next meeting will involve, perhaps we're pretty optimistic that we can look at the CQC report and the authority's response to that. And I think that will give us quite an agenda of things for us to look at over the coming year. And Alison, you've got, yes.
I think your plan, I think your plan is absolutely excellent. But it would be nice if we had it presented to us as well, because as we know of old, by the time we get to Cabinet, we in opposition are given the opportunity to say something at the podium, but we are never given the opposition to change the event. And it might be an extremely good idea if we were to air whatever you're choosing to present, so that we had an investment and a modicum of contribution along the way.
I mean, I would hope that most that if we're dealing with adult social care, we can almost approach these strategies in a cross-party way. You know, I think we've all got an interest. We want the best for every individual who's both coming into touch with our services. So I can't see that there's going to. I mean, I would hope that the political differences are minimal, perhaps.
Sorry, don't presume to assume.
Right, I'm corrected. I am corrected. We will take that as a challenge.
May I say
yes.
something? This is what democracy is about, and this is what we are doing for our residents. So I welcome it.
Yes.
Thank you.
Excellent. Good. Thank you. Have we done enough on this item? I think we've probably given ourselves a headache. So thank you for your contributions. Thank you, Mel and David, for your input. Yes, please.
Okay, thank you, Chair. So I'll summarise our action sheet, essentially, arising from this discussion. We've got 2 things on there. The committee's asked for refreshed data comparing suicide and self-harm in West Northamptonshire to the national average, and to be circulated via email. I'm happy to do that if you want me to. And also, we, Democratic Services, will organise an informal meeting with Place Overview and Scrutiny Committee on the Adult Social Care Sustainability Strategy, in particular the 58 work streams that sought to bring together existing budget targets and driving through new areas of efficiency and cost avoidance. And I will have a word with the chair of Place Overview and Scrutiny Committee and the responsible officers to try and get that organised sooner rather than later. Would February work for everybody? We are stuck for time and free evenings at the moment in the lead up to, obviously, the budget. But would that work with you, Chair?
My thought was that second group was going to be an ongoing group rather than a one-off meeting. I don't know whether, Ashley, your memory is better.
Yeah,
Andrew,
it says, I was just looking, it says working group, which assumes it's going to carry on rather than just, you know, obviously initially you'll show us what you're trying to do. But
yes, an inaugural meeting,
get that done in one meeting will be quite a task.
Oh, we'll have another headache, yes.
That February would be an inaugural meeting, Councillor, and we'll take it from there and determine in that meeting how frequently it needs to meet and what its terms of reference will be. Thank you, Chair.
Right.
Was there another action, what you just articulated, around looking at the strategies and working out when they should come to the committee?
Yes,
and
there
involve
is.
the committee, yeah.
Yes, please. So that would be an action for the chair and Place Executive Director to meet and just work out which strategies come to the committee when.
And was there an action about David and I meeting with you also to look at NHS and health scrutiny, to picking up some of the issues that were raised today?
Yes, I think so.
Do you want me to respond, Chair?
Yes.
Just with some of those bits, I don't think they're necessarily actions, but they're more routine work programming matters that are dealt with by the chair, members, officers. Once we've dealt with the CQC matter on the 9th of March, which is, I think, when we're anticipating it, that will obviously likely be a single item committee. Obviously, what comes out of that may lead to several different work streams for this committee. We're sort of coming to the end of the municipal year and the end of our work programme, so it may be worth giving consideration to perhaps an informal meeting of the committee to determine its work programme priorities for next year once the CQC item is dealt with, and amongst us as officers is something we can involve the members in as well.
Right, okay, so that's something for the minutes. So, and some actions in the minutes for us to meet with the Executive Director and Director of Public, or for me to meet with them to look, sort of do a pre-sift of the work programme for next year is what that is, isn't it, I think. Is there anything else that anyone... Yes, Adrian, come and rescue us from our...
Thank you, Chair. I put a scrutiny proposal form in 6 months ago, and it was going to be on this agenda, but it's slipped up. But I'm happy for it to go on the March agenda to give an extra 3 months to it. If you recall, it was the scrutiny of the new framework for adult service providers. I had some questions about that, and I'm happy to email Ashley the questions and a copy of the proposal form, and I'm happy to put it on there. It shouldn't take too long, I don't think. Is that okay? Can we do that, do you think?
Yes.
Yeah. Okay, thank you very much, Chair. Excellent.
Right. So is that concluding item 5 on our agenda? In which case we're on to adult item 6. And I think, Ashley, you're going to take us through this. How are we doing for time? I've lost 7:30
minutes.
Right. Do you think we can manage this in 30 minutes?
I certainly hope so.
Yes.
Obviously, I'm presenting this paper on behalf of Neil Cox, who was unable to attend today. So Well, we attended Scrutiny back in November, and we gave a bit of an introduction to workforce and the workforce issues that exist within the adult social care remit, and then some supplementary information was requested. So Neil Cox has provided a report which all members should have received. So I'm just going to talk through bits of that and then open it up for any questions on that one. So in adult social care, there's 966 directly employed staff. The vast majority of those they sit in health prevention and wellbeing, which is where our in-house care services are delivered. So that's your Reablement West team, that's the in-house care homes, it's supported living services. Those are all delivered in-house, which is why the very bulk of those sits in that health prevention and wellbeing. That also includes sort of occupational therapists and things like that within that area. Adult services has roughly 23% of all the staff, which is 221 staff, and then there's 20 staff that sit in the senior management bracket as well. There's huge volumes of staff. It represents a big proportion of all the council staff, but that's because of the lots of statutory responsibility that sits in adults and the breadth of that statutory responsibility that sits within there. So that ranges from Care Act assessments and undertaking reviews and our responsibilities under Prevent, Reduce, Delay, but it also has our responsibility for delivering in-house care services which come under a different regulation to our statutory services. So such a big breadth of things that we do there. So in terms of recruitment and vacancies, so within adults at the moment there's 110 vacancies for staff, and that's roughly 11% of the establishment. Most of the vacancies again are sitting, as you would expect, in the health prevention and wellbeing arena. As you can imagine, the in-house care services, the staff, they have the highest turnover rates. And therefore they command the most vacancies. So they're on a constant cycle of recruitment. There's always an advert out. It's really flexible on how people can apply. They express an interest, and then our in-house recruitment services will make direct contact with people, make it really easy to have an interview and do your checks and things like that because of that constant cycle of recruitment that's required. In adult services, so when I say adult services, I mean social workers and the social work teams, there's 35 vacancies at the moment, and then there's 5 vacancies in the management area. I'll caveat that a little bit because Mel, myself and Anne, who's taken over from Neil, are planning on what that structure is going to look like in the future for the management. So whilst there is vacancies, there's very little active recruitment happening at the moment for those. So a focus on the areas that are really difficult for us to recruit to, and I think we touched on them a bit last time that I attended. So social workers. National problem, really difficult to recruit them. So we have 7 social worker vacancies at the moment, and then we have 21 frontline care roles as well that are currently vacant as well in our regulator services, so in our services. Those are the ones we persistently find really difficult to recruit to. They're not like, massively unique roles where it's very difficult to find somebody who fits that. That it's the fact that there are more vacant posts across the country than there are qualified social workers, for example. And then, as I said, there's a lot of turnover in terms of the frontline care roles as well. So there's been a number of things that have impacted on our ability to recruit. So those roles have been vacant for over 6 months, which I think is why we're highlighting that they're quite difficult. It does reflect the national workforce pressures, and we have competition from the NHS in terms of similar sort of roles, sort of healthcare assistants. And then there was some tightening of visa rules, which has impacted us back in April in terms of recruiting internationally. So in terms of staff turnover, it's remained relatively stagnant for the last 3 years. It's not where we want it to be, and the difficulty is it's not all over adult services. It's focused in areas which then generally puts pressures in those areas. So the percentages can be slightly misleading on this, but it's been between 15-14% over the last 3 years in terms of staff turnover rate. It's above the national figure. For for staff turnover. So there does tell us there's still more work we need to do to keep talent that we get, and things that's something Mel and I and Anne are sort of having conversations about at the moment. Specifically for social workers, we're sort of behind the curve in terms of our retention of qualified social workers, and that's a part we need to kind of work on in terms of providing those career aspirations and those things that will make a difference in terms of them wanting to stay. So why do we see those pressures? So I've already kind of talked through the main reasons why, but what we're doing about it is we're competing directly with the NHS recruitment campaign, so they're like ongoing constantly. Ours are ongoing constantly as well. We're obviously doing our work to support the new number of newly qualified social workers get it out eventually. So we work with the University of Northampton, and we do our sort of apprenticeship style approach, and we do our practice education roles within our internal service. But I think we talked about it before, that there's only, in order to sustain the business, there's only so much we can do in terms of training internal staff, despite interest being higher, because a lot of staff time is required to not be doing the day-to-day job and to focus on getting their qualification and getting their degree in social work. So we have to kind of balance that one really, really closely. But we do all of those things to do that. We introduced back in September some digital rights to work checks, which also helps us to sort of streamline the pre-employment checks needed to get somebody started. So that's particularly useful for roles where you need a really quick response, and that's the frontline care service roles. So all staff are required who are going to be delivering personal care and sport required a DBS check beforehand. So we've introduced measures to streamline that, because it was quite lengthy time, and sometimes you could offer somebody a role and it'd be 8 weeks later that you'd be able to start them. And for these sorts of roles, people lose interest, and that's what we don't want to do. We want them to show an interest now and start them tomorrow as much as we can. So we've done the targeted campaigns for hard-to-fill roles. There's evergreen adverts and multi-platform promotion that we're doing around those difficult roles. There's weekly proactive candidate outreach. So if somebody goes onto our recruitment portal and even has a look at that, creates an account and has a look and doesn't finish an application for it, then we proactively reach out to them and talk to them about their interests and how we can support them to make those applications, specifically for frontline worker roles. We've got a dedicated social work careers page as well, which highlights the benefits and what it's like to work in the teams and the progression opportunities that sit within adults. So this resulted in 18 new social workers recruited in 2024 and 19 more recruited by October 2025. So it does work, but then the challenge there is then when you combine it with a higher than national average turnover rate, there still remains vacancies. It's still posts that still remain hard to fill. So that's kind of where we are. But I think I'll kind of look at some of what we're going to do next in terms of things, because I don't think I've told you anything particularly groundbreaking on that, but there's some work we've got to do. And Mel and I had a conversation about this earlier in terms of restarting our workforce capacity board or workforce board, which I think has had a bit of a pause. But we want to get that and probably reinvigorate that and start to drive that in terms of getting the right capacity and understanding the right capacity that we need. So we're doing some salary benchmarking work as well at the moment, and I think we discussed that before in terms of challenges around salary. We're reviewing the international recruitment criteria following the visa changes and looking at further opportunities on our ability to recruit externally. We're continuing with our training and development and looking at opportunities to bring people in who want to become qualified social workers and sort of helping them to get that foot in the door as well. And career progression. So once you're a qualified social worker, what happens next? And do you want to be the next Melanie Williams? Do you want to be the next Ashley Ledoux? Probably not, but you might do. So we want to share that pathway out with people and sort of look at that development plan for them to show that we're not, it's not investing in them for today's problems. We want to invest in them because we have an interest in, their entire career. So those are the things we kind of want to talk through. I think agency usage was something that we talked about before, and there's, again, the very vast majority of agency usage is in our in-house provider services, and you can probably understand why it's more, because if we looked at our establishment and we said, our establishment is exactly what we need to deliver care for today's people, and then tomorrow there's one extra person, then the staffing isn't enough. But similarly, at the same time, if somebody goes off sick or somebody's absent from work, or those turnover rates that we talk about, we have to fill them quickly, because the most important thing is for us to have safe staffing levels to deliver safe levels of care for people. So the agency usage is kind of end up working out a bit cheaper than actually having additional recruited staff on fixed term contracts and things like that, when you know, the short term nature of agency staff can actually lead to financial benefits. So I just kind of wanted to explain that too. But from April to December of 2025, we spent £1.86 million on agency staff. That was split out between the senior management budget, the adult services budget, but again, the very, very vast majority of that sat in the provider services budget, as you would expect it to. From an adult services perspective, it's having locums. So locum social workers. So we had some really big projects that needed to be delivered that would deliver savings for us. They can't be delivered without qualified social workers. So whilst we spent it, the savings that we generated from that greatly outweighed what the cost was for that. So, but it was still counts as agency spend. And then from our in-house perspective, as well as with the recruitment challenges, the high turnover, and the difficulties I think we've talked about in the previous meeting about staff sickness in provider services, is that the use of agencies obviously something we've had to rely on to sustain those safe services. We do, the very vast majority of agency staff go through Opus, and Opus is our contracted recruitment partner, designed so that we can get the, you know, the best rate and good value for money, but also a really fast, efficient service from them. So it's 70% of them we use through there. Where we can't get them through Opus and there's challenges with them, that we go out to the wider market to do that. And obviously we I think from our workforce planning perspective is that we want to get our agency numbers down as low as possible, but we do have to accept a certain proportion of agency staffing because it is something that's required when you're delivering in-house services. But for the other areas, we need a sort of a better and more robust plan in terms of how we're going to get those numbers down. You'll be excited to know that there is a sustainability plan action. It's one of the 58 around the reduction of usage. So there's a specific project that we're working on on how we're going to get that agency usage down. I think I'd be naive in saying we're going to get it to zero, because I don't think we want to get it to zero. Our only way to get it to zero would be to spend more money than we would need than our established budget because of that cover requirement. So yeah, does that make sense? And obviously, there's some stuff around that I talked around about that Mel and myself and Anne are picking up around that workforce work. But there's other things that we like to do in terms of promoting staff and making them feel valued. So we obviously offer the services to mental health first aiders and the employee assist program and all the wellbeing courses and things like that. And all of those are sort of like designed to help manage that absence, but also to help those staff feel valued. I think from that perspective, we're pretty much, I think that covers the majority of the paper in there, and I'm happy to open up to any questions that we might have. We do have a dedicated workforce board. It does need to relook at this, and I think it paused for a bit, and I think we are going to push that further and sort of look at where the gaps, then there might be missing actions in terms of targeting those challenging areas. But we do recognise the value of the staff, and they are really important to us. And I think I just want members to know that this is a massive priority for us as a leadership team in addressing some of the issues that I've talked about today.
Yes, thank you, Ashley. That's really helpful and really useful paper, I think, for us as a committee. And this area of work is a people's service. It is about people. So our workforce is our great resource. You know, IT can do so much, but at the end of the day, it's a people's service that we're into, and we need to make sure that we've got the right people in the right places, feeling fulfilled with a plan for their careers, really. And I think it's also has been clear that, well, probably for 50 years, that actually as a nation we have not valued our social care workforce as much as we should have done. And that needs to change. And I think it's up to us now in this period of time to actually make that difference. Now, how we do that, I think, is very challenging as a society because of the financial constraints. But we've got to find ways so that people within adult social care working there feel valued and make a real contribution to the community. So that's enough. Right. Let Adrian and then Andrew, and we need to work out what and Alison as well. And it would be really good if we have what are the action points that we as a committee want to take forward. How do we want to support this area of the council's work? Because I do think this is absolutely key to what we're about as a committee. Yeah. Adrian.
Thank you, Chairman. I'm looking at these numbers. It looks like you've got like sort of 14-15% churn, but you've got a 10% understaffing, and then about 10-11% in and out to make that there or thereabouts. Reading from that, is it a steady 80% that are steady then? Is it right to say that it's just certain job roles that are churning? And other roles that we're just not filling, and we have a stable 80% of staff. Is that a fair assessment?
Yeah, absolutely is a fair assessment. I think what I was highlighting is that there's two particular roles where we do have churn for them, and I think social workers is one of them because there's such high demand nationally for qualified social workers. There's opportunities for people, so there is churn for those, and obviously as well being a shortage in terms of re-recruiting or recruiting those. But the majority of that number is represented by sort of our in-house care, frontline care workers, where, to be honest, we do accept that there's going to be natural churn because of the nature of the role and the difficulties that surround it. And that's why we constantly have this evolution, this circle going around in terms of recruitment. So it is those two particular roles. Generally, the workforce, particularly in adult services, is steady. It is a steady workforce. There are vacancies where there are gaps, and they are difficult for us to fill. But it isn't like it's that churn is the churn seems to be kept to within that 20% mark in terms of those. But the 80% of the workforce is very, very, very stable. It does lead us to some challenges in terms of how quickly we can get to things. But hopefully with the new refreshed workforce approach that we're looking at the moment, we can address some of those and start to address some of those waiting lists.
Great, thanks. I thought you'd have somebody sat at the university door not letting them out until they came here. Thanks very much, Chair.
Yeah, thanks, Chair. I just wanted to check so I understand the numbers a bit, because so 966 is the full-time equivalent. If you have everybody employed, you'd have 966 in there. 110 are vacant at the moment. The agency staff of 109, presumably they're making up for the fact that you've got 110 people that you should have, but you haven't got, and also dealing with flexibility, or are they an addition? Because if you add them to the 110, then you've only got 647 out of 966.
It's a mix. I think it's a little bit of both. So there's 966 directly employed staff. There's 109 agency staff on average at any one time, but it's a mixture of hours. So it's not necessarily 109 full-time staff that are within that. So we could recruit somebody, an agency staff worker, to cover a weekend, and at the time the data was pulled, it's included them within it. But it's just kind of looking at the averages at that point. And Mel, add into that.
Sorry, we need more microphones next time. So we have both planned and unplanned interim and agency workers. So what we'll have in the service is where we have a short-term project. So Ashley at the moment is leading a short-term project on income. So we deliberately employ people on short-term contracts to do that piece of work for a short time. So that'll be some of the agency, and some of the agencies more linked to absences and other things in provider services. So what we can do is we bring this report regularly, because I'd expect us to have this as part of our performance report, Chair, into the future, is that we can give more of that context, so we're really clear about, because the goal is that we have planned agency where it's cost effective to do so, and where we minimise unplanned agency, but we can distinguish as we get more sophisticated with the data.
Thank you for that. The other question I had on that was, if 966 is your full-time equivalent, what you should have, how do we know that's the right number? Is this part of the workforce planning that you're doing to see whether you should have more than 966?
Yes, I'm going to say the words again, Councillor Simpson, but it's one of the sustainability plan actions of the 58. One of them is around our workforce capacity. So we have a particular project that's actually doing a refresher, or saying actually there's been quite a lot of change over the last 12 months, 18 months sort of thing. Is the workforce still what we need it to be? Are we as efficient as we should be? And are there opportunities where we've sort of introduced new technology and things like that? Is our establishment number what we would expect our establishment number to be? So we're doing that, a piece of work around that, which might reflect that the 966 is too much or too little. But the robust understanding of what's actually required is missing, but it's one of our priority areas that we're looking at putting together, and happy to bring that back as part of performance reporting later. Yeah.
Just to let you know, I come from a commercial background. And when you recruit...
Alison, could you...
Oh, my...
Yes, the world cannot hear you.
The world can't, but you can.
I can, yes.
I'm so sorry. I come from a commercial world. And the one thing I've always noticed is that however much recruitment you do, if the workplace is not a happy one, it's quite difficult to keep your staff. So my question to you would be, in that we've had a mammoth turnover, we've also had a turnover in our leadership and our governance. Do you think you are providing what is needed for these recruits, or is the expectation of the recruits really beyond expectation? So it's not justified. I mean, you know, there's no doubt about it. If you provide a happy work environment with good interchange, shared time at lunch, a working weekend, an exit group, all that sort of thing sometimes, and a learning curve, because this is what you've talked about, of bringing people in so that they realise that coming for the learning curve, there is a future to stay, even though for a period of time they might be miserable. They can sort it out and resolve because there is a future. In that you've had we've had a mammoth change, and all of us have had to adjust our sights. Do you feel that you, at long last, might have got yourself on the right footing?
So we've got two tools that will help us understand that, because to be honest, Councillor Eastwood, I can't say is how well all of the people in our department feel about their work at West North Hants. So we have what's called the social work health check that's undertaken every other year. That wasn't undertaken for the last 18 months. We're just about to undertake that again regionally, aren't we? That will give us a really good example of how social workers and occupational therapists, so our regulated professionals, feel supported at work. As an organisation, a whole council approach, we've just undertaken the employee wellbeing survey. Was that the end of, I'm just thinking, actually it was December, wasn't it? We all completed that. And that will give us a broader council view. But I think you're absolutely right. So there's been a check, you know, Stuart Lakenby was my predecessor. There's been quite a long gap before I came. Neil Cox has now left, and we were just recruiting the team. Ashley's undertaken a reorganisation of his services, and there's a consultation at the moment. So there is quite a lot of change, and we know that unsettles people. So I think we don't really understand that fully. I think West Northants has a really great employee offer. It's one of the things that attracted me to come in here. But we also know still that may not be enough for people. So I think we're still undertaking that work to understand some of those impacts. So that's being entirely honest.
Thank you. It's not because I wish to rock the boat. It's to open a discussion of what could happen for the future that means that you can keep your recruits, not show them the door within 24 months.
Thank you, Chair. Along a similar line, do you keep the data on sort of, are they newly qualified that are leaving? Maybe they've realised when you actually get into the work it isn't what they wanted, because there's more pressure. You want to help people, but you suddenly realise you're dealing with real issues and it affects them, and they leave. Would you know that? Do you have that data, or is that part of it?
That comes into the health check. So I think actually, I don't know, it's not in the report, but what we understand about exits, for newly qualifieds, generally they stay in role, but they may well move for promotion. So there is a lot of mobility in the younger workforce, but equally, as Ashley said, we've also got really strong retention. There are a number of Northamptonshire lifers within the service, so we've got really strong retention in some groups. But the health check will understand us more about some of the qualified practitioners. But bear in mind, we've got quite a diverse skills mix. So we have social workers and occupational therapists who are regulated, qualified professionals, and we have a large amount of staff who are really valuable, both in direct care roles and in more commissioning type roles in the organisation. So it's quite a mix.
Thank you very much. Any further questions of Ashley? Yes.
Not on that topic, sorry, but I have gotten any other business, so I don't want you to wrap up before I get a chance to raise it.
Right, OK. We'll...
What's it about?
Yes.
Does it relate to an agenda item?
Is it part of tonight's agenda?
No, it's something that's been... I've been written to about it, and I wanted to raise with here because we've got people who could...
Do you want to email Mel about it? I'm sure...
I've emailed it to you, but let me just... Just because it for Laura as well. And I don't know why they wrote to me or whether they wrote to everybody else, but it's about the devastating impending closure of Deaf Connect.
Yes, they've written to all of us.
Oh, right, okay. So I don't know what's happening about it.
Yeah, I'm happy to provide well, we have provided a brief, and we've, and I don't think it's been circulated to all members yet. I think it's in the final stages of it, but obviously, just to be aware, there's two ways in which we have supported Deaf Connect, or they've asked for support. So they do some adult social care commissioners commission them, hosted by Northants. It's a county-wide contract to provide some statutory, but mostly non-statutory support for people who have hearing difficulties. It's a very small contract. I think our contribution is 20,000 per year, £20,000 per year, and North is a similar sort of value. It came out the blue to us, and we were a bit surprised, but we have worked with Northants commissioners who are still working with Deaf Connect to understand those issues and where there's possibilities that we might support them. However, there is a chance that might not happen, and if so, we will work with them and we'll work with the people who access their services to, look at alternatives that can happen. But we'll communicate that to you when we're more clear on what that might happen. Yeah. We'll get a briefing out, but we've got very close eyes on the situation. So please be assured, yeah.
Thank you, Ashley.
Can I just add to it?
Yeah.
I think it hit our tables yesterday or the day before yesterday, and there were a lot of people who were slightly startled by it, just as you said, it came from nowhere. And obviously it'll take time to consider as to what you can do about it. There are some people who are being very strident about a demand dictate that we as WNC will fund.
Thank you. So we're on to the work programme. Would you like to
Thank you, Chair.
take us forward?
So in terms of the work programme, our next meeting is on the 9th of March, during which we will receive the outcomes of the Care Quality Commission inspection of the Council's adult social care function. Prior to that, we've got an informal meeting on the 10th of February, jointly with the Children, Education and Housing Overview and Scrutiny Committee on the Council's Home Adaptations Policy. That is pre-decision scrutiny that's been requested, so I can invite the relevant Cabinet members and officers to that if you wish to come along. In terms of the work programme beyond the 9th of March meeting, our final meeting of this municipal year is the 23rd of April. We will deal with, I would suggest, the 9th of March first and see what work streams come out of that meeting. And then post 9th of March is probably the time for a wider conversation between the committee and the officers on next year's work programme. If everybody's happy with that course of action between us, we have our catch-ups with the chair and senior officers, so we can start to put some ideas together on next year's work programme and bring that back to committee at a later time. And that's it, Chair.
Right. Pete, is everyone happy with that as a way forward? It sounds like... Yes, Andrew.
I was going to say, obviously, we've talked about the working group, and that some actions will come out of that, and some of the stuff that Ashley was talking about, that we're looking at in that working group. So.
Yes, and we've very much had our adult social care head on tonight. We've also got to remember our... Yes.
Apologies, Councillor. Included in that is obviously the work programme that we've discussed earlier, so I'll send an email to the Chair of Place and Resources tomorrow and get the ball rolling on that. Obviously, the reason why it involves Place and Resources as well is obviously they have responsibility for scrutiny of the corporate finance element of the organisation. So it'll be 3 and 3, and we'll take it from there.
Excellent. We've also got to bear in mind some of the health issues that we want to do, and how do we make sure... I'm slightly... my sort of reflection on so far is that we've dealt, and it was my decision that we dealt with things in silos this year. We'd have a meeting focusing on communities and one on health and this. But we've got, actually, the challenge next is how do we join these up so that we involve the health people in the discussions that we've got? How do we get that right? And if people have ideas on that, I think I'd be very grateful to receive them, because I think it's a challenge for us. Silence. So can I thank you, Richard, for that update. Are we agreeable to that as a way forward for this? Can I thank you for your attendance this evening and your contributions, and to our officers for their input, and to David as well. I think we've had actually quite a heavy agenda, so thank you very much, and we look forward to the 9th of March. Thank you.